understandable to the audience as possible. Well, in the beginning, I'd like to thank Professor Bajaj because he thought of such an important topic. We keep on talking, at least in hepatology, hepatitis B, hepatitis C, causes of cirrhosis, but he's picked up a topic which actually is a problem for all of us and has been ignored by all hepatologists and otherwise as well. Well, alcohol, as you know, is the most frequent and socially acceptable hepatotoxin. There is no party that is successful without alcohol. There is no marriage where if alcohol is not served, it would be well taken. So it's become a socially acceptable hepatotoxin. And it affects the liver, depending on the dose and the duration. But you need to remember, since I see a lot of undergraduates, if one is a heavy drinker, there is a 90 to 100% chance of developing fatty liver. There is a 10 to 35% chance of developing alcoholic hepatitis, about which I'll discuss with you a little later. And 8 to 20% of these people ultimately develop cirrhosis liver. And this cirrhosis is usually micronodular, except when the patient has abstained from alcohol for a long time. Dr. Bakshi has already told you about the alcohol content of beverages and what we usually use as a standard to tell how much of alcohol is harmful. 10 grams of alcohol is present in 30 ml of whiskey, 120 ml of wine, and 360 ml of beer. Why is it that all people who take alcohol do not develop liver disease? One thing you need to realize that the subset which usually gets affected with liver disease is the one who has a low educational level, low income, unemployed, job alienation, job stresses, and no job satisfaction. Although there are many others, affluent people who also get affected, but most of the people affected in clinical practice belong to this group. Many years ago, rationing and prohibition done in the European countries way back in the 50s or 60s, or when the cost of alcohol was increased, brought about a change in the incidence of liver disease during that time. Unfortunately, what was practiced in Haryana some time back, the alcohol incidence did not come down significantly in spite of prohibition, and that was through the use of illicit liquor. But one thing which is important to realize is drinks outside the meal time increases the chances of liver disease. The most important factor which brings about changes in the liver is the quantity of alcohol that is taken by an individual, and the safe limit would be for males well below 60 grams per day and for females well below 20 grams per day. And if this amount is taken more than that for 10 years, there are chances that an individual would develop liver disease. But wine tends to lower all the causes of mortality, and hence it is slightly hepatoprotective, although one cannot give that liberty to have. It's also been seen that Indians are more affected with liver disease as compared to the other groups. And this has been highlighted from studies in UK where the Indians and the Europeans drinking the same amount of alcohol tend to develop cirrhosis more often. It's also seen that we did some studies in Chandigarh where the illicit liquor was found to have more of trace metals, more amount of alcohol as compared to what I just mentioned, whiskey having 40% alcohol. The Indian-made foreign liquor not being standardized had values as high as 60% with a very significant amount of lead, arsenic as the trace metals. There could be some reason for genetic polymorphism and comorbidities responsible for increased prevalence or the incidence of liver disease in the Indians who are staying abroad. Women are more prone to develop liver disease if they drink, and as I had mentioned, the limit of steroidogenic dose for women was less than 20 grams. Anyone drinking more than 20 grams, more likely to develop liver disease. And the reason being, it is said that alcohol, once it is taken, gets metabolized in the gastric mucosa by alcohol dehydrogenase, and this is present more in females. So acetaldehyde is present, the levels of acetaldehyde are much more higher in women. Secondly, it's also said that endotoxemia is it happens more often in women because of the leaky junctions within the intestine of the mucosal membrane. It has always been thought that malnutrition is a significant factor for development of liver disease in an alcoholic. Even obesity has been found to increase the risk of liver disease. In clinical practice, if you take 100 patients of cirrhosis coming to you, at least in Chandigarh, majority of them have cirrhosis because of alcohol, followed by hepatitis C. In other parts of the country, it is hepatitis B which is more prevalent. But in Punjab and Haryana, obesity forms the third important cause of cirrhosis liver. And when alcohol and obesity, both of which are common in those two states, the chances of developing liver disease becomes much more higher, almost 5 to 6 times. And this is because of increased hepatic insulin resistance in obese individuals and increased tumor necrosis factor. These patients, the malnourished individuals, have vitamin A depletion, and depletion of vitamin A within the hepatocytes activates the stellate cells, which you know is important for the formation of fibrosis. With decrease in vitamin E, because of malnutrition, there is increased membrane lipid peroxidation, which again is an important reason in the pathogenesis for liver disease. Co-infections with hepatitis C and hepatitis B also is more common in alcoholics because of their high-risk behavior. And whenever these hepatotropic viruses are combined with the insult because of alcohol to the liver, it produces synergistic liver injury. Hence, these individuals develop liver disease at a younger age, more likely to develop hepatocellular carcinoma. And in India, almost 30% of alcoholics coming with liver disease have associated hepatitis C infection. Iron overload also is a factor which increases the chances of liver disease in alcoholics, and genetic factors are also being considered to be important reason for development of liver disease, because as I said, the toxin is acetaldehyde. So metabolism of alcohol into acetaldehyde is important. Faster the metabolism into acetaldehyde and slower the metabolism of acetaldehyde into acetates, these are the individuals who are likely to get liver disease. And this is by the two enzymes, alcohol dehydrogenase C21 and acetaldehyde dehydrogenase ALDH2 and 2. So what basically is the pathogenesis of liver disease in an alcoholic? It is an interaction between the metabolism of alcohol, the inflammatory response, and the immune response. So all these three are very essential for development of liver disease. And as I said, alcohol dehydrogenase pathway increases the levels of acetaldehyde in the body. It directly damages the hepatocytes by forming acetaldehyde adducts, and which becomes immunogenic, and antibodies are formed. There is also increased expression of pro-inflammatory cytokines. There is another pathway which metabolizes alcohol, and that is by way of cytochrome P450 2E1, which increases the development of reactive oxygen species important for damaging the hepatocytic membrane and the mitochondria. Polymorphism in the pro-inflammatory cytokine IL-10 also tends to get affected. There is downregulation of TNF-alpha and type 1 collagen, and there is development of autoantigens which leads to damage of the hepatocyte. There is also indirect hepatocyte injury by way of cytokines of the Kupffer cells, and increased lipid peroxidation activates the hepatic stellate cells. So how does alcohol affect the liver? The different spectrum that we clinically see is alcoholic steatosis, which is a relatively benign condition, but majority of the individuals do develop steatosis of fatty liver. The other important group is alcoholic hepatitis, which would develop in another small percentage of cases where there are abnormalities in the liver enzymes. The patient becomes jaundiced, and this could be either mild or severe. Mild has a relatively good prognosis, severe has a very bad prognosis. Some of these patients go on to develop cirrhosis, which may be compensated when there are no symptoms to suggest cirrhosis, or decompensated when they develop jaundice, ascites, and fetal fever. Then there is a new term known as acute and chronic liver failure. This has been in vogue for the last 4 or 5 years. And we used to see these group of patients very often till we realized that this is a separate group of patients who have high mortality, and you need to do a liver transplant in these cases if there is no reversibility of liver disease with therapy. So you define acute and chronic liver failure as any person who's been drinking alcohol, develops jaundice, and develops ascites within 4 weeks. Within 4 weeks of development of jaundice. Patients of alcoholic liver disease also are more prone to develop HCC. Although alcoholic hepatitis is acute, when you do a biopsy in these patients, 50% of them have established cirrhosis. And one should always suspect cirrhosis if, even after abstinence of alcohol, patient still is symptomatic. This again is the statistics that we've had last year of patients at BGI, where of the 478 cirrhotics, alcohol constituted 58% of the breast incidence. HCV was 20%, HBV 12%, and cryptogenic, or in other words, NASH, non-alcoholic steatohepatitis, was 15%. And this is increasing because of increased consumption of junk food and more obese individuals. When we looked at our hepatocellular carcinoma data, again almost 13%, the cryptogenic group, had HCC because of obesity, and 14% had because of alcohol. And co-infection with hepatitis B and C again was an important cause of HCC. This is our own publication of the acute precipitants in acute and chronic liver failure, where we found that quite a significant proportion of patients had ACLF, or acute and chronic liver failure, because of alcohol. Where alcohol was the acute precipitant, it could be hepatitis B, C, E, over an underlying chronic liver disease, which again was alcohol, to be most common in the Indian group of patients, at least in Punjab. So how do you diagnose a patient with a liver disease because of alcohol? Certainly, it should be in the context of significant alcohol data. There should be supporting laboratory data, and one should, from a psychologist's point of view, look at whether alcohol affects the daily functioning of these patients. But an alcoholic cirrhotic is different from another cirrhotic by way of increased chances of parotid enlargement, more spiders, they have Dupuytren's contracture, and patients with alcoholic hepatitis, along with cirrhosis, would have a bruit over the liver. The other causes of bruit over the liver is hepatocellular carcinoma. So you have only two conditions which produce a bruit or a murmur over the liver. One is hepatocellular carcinoma and the other is alcoholic liver disease or hepatitis. These patients are also prone to have other dysfunctions like cardiomyopathy, sarcopenia, pancreatic dysfunctions, and neurotoxicity. When you look at the laboratory abnormalities, the history being significant for alcohol, the transaminases, that is the SGOT and SGPT, is not as high as what you would expect in viral hepatitis, where it is in thousands. In alcoholic liver disease, it would be 2 to 6 times raised above the upper limit of normal. And if the value of SGOT or AST is more than 500, think of another etiology. And if of AMD or SGPT is more than 200, again think of another etiology. The AST-ALT ratio is another way of diagnosing these patients. The ratio in the garden variety of hepatitis, AST is always more than AST, so the ratio is less than 1. But in patients with alcoholic liver disease, especially alcoholic hepatitis, the ratio is more than 2, AST is always higher than AST, and if the patient has evidence of cirrhosis, the ratio is more than 3. So it's a guide for you to think in terms of alcohol as an etiology. They have high WBC count, macrocytic anemia, hyperglycemia, hypertriglyceridemia, and hyperuricemia. Liver biopsy is rarely indicated except if you want to have confirmation or to know the severity of liver damage, and there are some specific features like mammary hyaline bodies, neutrophilic infiltration, fat, macrovesicular fat, and micronodular cirrhosis with creeping fibrosis around the hepatocytes. Imaging is not of much help except you get a pseudoparallel channel sign in patients with alcoholic hepatitis, not an ultrasound. Ultrasound in biliary obstruction tends to produce dilatation of the biliary ducts, which are not normally seen. You only see the portal vessels. But in alcoholic hepatitis, there is no biliary obstruction. The hepatic artery tends to get dilated, and that is how you get a parallel channel sign. And these are some of the pathological findings of steatosis, cirrhosis, and fibrosis and hepatocellular carcinoma in an alcoholic. Prognosis is extremely good in patients with fatty liver disease. Survival is 50 to 75% at 4 to 5 years in a patient with alcoholic hepatitis and cirrhosis, depending on the hepatitis if it is mild or severe. And in acute and chronic liver failure, 30 to 50% die at 3 months. This again is a study from our own institute which we published some time back, where we showed that if one has to prognosticate in patients with acute and chronic liver failure, the Apache 2 score and SOFA score, which are important for organ function, are the most important parameters to prognosticate in these patients, and go ahead with a liver transplantation if the patient doesn't improve within a specified period of time. But there are other prognostic models which tell you how aggressive the treatment should be done, especially in the group of alcoholic hepatitis, because alcoholic hepatitis doesn't give you much time to treat. If the patient responds within a week, 2 weeks, or even 3 weeks with medical therapy, it's fine. But if the patient doesn't respond, go ahead with the liver transplant, otherwise mortality is very high. But one way of prognosticating is the natural discriminant function, which is a product of 4.6 multiplied by prothrombin time of the patient minorly controlled and serum bilirubin, and if the value is more than 32, mortality is high and these patients need aggressive therapy. MELD is another score which we use in liver transplant. All cirrhotics cannot be taken up for a transplant. So if the MELD score goes beyond 15, the patient becomes a candidate for a liver transplant. The full form is the Mayo End-Stage Liver Disease Score, which was incidentally brought about by a pathologist from PGI, Patrick Kamath, almost 10 to 15 years ago, and is the standard for any liver-related prognostic models. Then you have the Glasgow Alcoholic Hepatitis Score, which was used from Glasgow, UK, and that also prognosticates whether this patient needs very aggressive therapy or just an ordinary therapy. And there are dynamic models which say that if the MELD does not improve over a period of 1 week by 2 scores, patient should be taken up for transplant. So abstinence is absolutely important in these patients. Most of them improve if they have fatty liver within 3 months. Patients with mild alcoholic hepatitis who don't have a raise in bilirubin also improve with abstinence. But the major problem with these patients is recidivism. They go back to alcohol, and this is seen in about 60 to 80% of patients. And to prevent that, you have naltrexone, acamprosate, which has already been alluded to by Professor Chadha. But baclofen, which is considered to be very safe in patients with liver disease, is considered to be a good drug which prevents patients relapsing into drinking alcohol again. Since obesity is common in such patients, lifestyle modifications like a little bit of exercise and better nutrition is important initially for such patients. Again, this study shows that baclofen significantly improves the chances of recidivism in these patients, in turn improves survival to a little extent. Nutrition is very important in such patients, since we know that malnutrition is common and assessment of malnutrition is difficult. These patients have arthritis, so the weight is more, and getting into BMI is problematic. They have low albumin levels in any case. Anthropometry is not important because in any case they have sarcopenia. So the usual way of assessing malnutrition doesn't hold true in patients with liver disease. The best indicator is creatinine height index considered in such patients. And aggressive nutrition is important because studies have shown that hepatic regeneration and reversal of sarcopenia happens if a good nutrition with a protein of more than 1.5 grams per kilogram of body weight and calories more than 30 kilocalories per kilogram of body weight improves the chances of the prognosis in such patients. If these patients are not able to take voluntarily orally, then small bore feeding tube also can be given to such patients. Another recent recommendation is these patients should be given a nighttime snack, say around 12 o'clock or 1 o'clock, because again studies have shown that if they are given the total amount of calories breaking into every 3 to 4 hours, the chances of recovery is higher. Liver multivitamins should be given, and branched-chain amino acids if there is overt hepatic encephalopathy, since it is expensive. Steroids have been extensively studied because it is anti-inflammatory and it is immunosuppressive, has an anti-fibrotic effect. But a large number of trials and meta-analyses have shown that steroids are effective only in a select group of patients who have severe alcoholic hepatitis and do not have any evidence of bleed, hepatorenal syndrome, and infection. In our own clinical practice, steroids tend to produce infection in these patients who are already immunosuppressed, and we haven't had very good responses to steroids in patients with alcoholic hepatitis. There is a limit score where you can give a chance 1-week trial of steroids to these patients, and if there is a fall in bilirubin, the limit score takes into account age, bilirubin, serum creatinine, albumin, prothrombin time. And if in 7 days you are not able to bring down the bilirubin, then the patient is likely to be a non-responder and becomes an indication for liver transplant. People have tried anti-cytokine therapy, decrease somehow the levels of tumor necrosis factor, interleukin 1, 6, and 8 by using pentoxifylline. Initial studies have shown good results, but meta-analysis of a number of studies now have shown that it also doesn't work very much with the type of patients that come to us who have a very high MADRI score and who are in extreme severe alcoholic hepatitis. The only advantage of pentoxifylline is it prevents the development of hepatorenal syndrome or renal failure in such patients. People have tried infliximab, etanercept, which are both anti-TNF, antioxidants, corticotropins, uracil, and polyamide phosphatidylcholine, but they have not shown to be very effective in these patients. And some new potential therapeutic options are there in the horizon, but have yet to prove the test of time. Liver transplantation in these patients has always been very controversial because with the shortage of liver in especially the capillary growth, one tends to feel that this is a self-inflicted disease, and hence these individuals are not worthy of getting the liver transplant. But there are people who believe that in that way the self-inflicted diseases are hepatitis C also, which happens in intravenous drug abusers, those who haven't had blood transfusions properly. So you should not give liver transplant to them as well. So as of now, liver transplantation in alcoholics is usually done if there is total abstinence for a period of 3 to 6 months. Otherwise, as I said, recidivism or relapse into alcohol happens, and hence it is given to these patients if they are abstinent for 6 months. And results are supposed to be better in alcoholics because the chances of rejection, graft failure, and need for retransplantation is less common. So this is another study where they say that if the patient doesn't improve, this was published 2 years ago, if the patient doesn't improve in 2 weeks' time, a patient with severe alcoholic hepatitis with a MADRI score of more than 100, patient should be taken up for a transplant. Well, that's all which the organ which alcohol tends to affect mainly. But there's another organ in the GI tract, pancreas, which also gets affected in these patients. And alcoholic pancreatitis forms almost 1/3 of the total patients with chronic pancreatitis that come to our unit. And this was published way back in 2008. The commonest reason being idiopathic for chronic pancreatitis, although we all know that acute pancreatitis is mostly because of gallstone disease. And the threshold for development of alcoholic pancreatitis is not as well studied as in alcoholic liver disease, but it is said that more than 150 grams of alcohol per day for more than 5 years is a relative good threshold for development of alcoholic pancreatitis. But only 3 to 15% develop it, so there must be some cofactors. But patients with the chronic pancreatitis because of alcohol usually present with recurrent abdominal pain, which is unrelated to food, and about less than 10% of them do not present with pain, but with exocrine and endocrine deficiency. Exocrine deficiency is by way of steatoria, and endocrine insufficiency because of development of die disease. But this pain, over a period of 10 years, patients keep on coming to you with repeated pain. But this pain gradually gets burnt out over a period of 10 years. As in alcoholic liver disease, even pancreatic functional changes tend to occur in spite of cessation of alcohol. And studies have shown that exocrine insufficiency occurs in those who have not had in the beginning, after about 13 years of presentation, first episode of painful chronic pancreatitis, endocrine insufficiency in 1/3 in about 20 years' time, and pancreatic calcification that you see on plain X-ray abdomen occurs after a period of 8 to 9 years. Now, why is it that some patients of alcohol, increased alcohol consumption, develop liver disease, the other group develops pancreatitis? Was clearly studied in an autopsy data where majority of patients with alcoholic liver disease had subclinical chronic pancreatitis, and about 18% of cirrhotics had evidence of alcoholic pancreatitis, which was partly symptomatic. Whereas when you took all patients with alcoholic pancreatitis, 30% of them had silent alcoholic cirrhosis. And whenever a patient with alcohol consumption comes to you with severe pain abdomen, and if you do a biopsy for any reason following surgery for pancreatic necrosis, there is always evidence of chronicity. Genetic factors are not very important as compared to the liver disease, so there is no role of alcohol dehydrogenase and CYP polymorphisms. Smoking in these patients is more likely to develop chronic pancreatitis and pancreatic cancer. Diet high in fat and protein and deficiency in antioxidants, again, is a predisposer for chronic pancreatitis. And here again, possibly the culprit is acetaldehyde, but it has not been well studied. And abstinence does not halt the progression of endocrinal and exocrine insufficiency, but increases the rate of progression of both pancreatitis as well as these insufficiencies. So friends, in conclusion, I would say that alcohol mainly affects the liver, but also tends to affect the pancreas. It has little effect on the gastrointestinal tract except in the form of erosive bleedings. But the spectrum, as I said, of alcoholic liver disease is fatty liver, alcoholic hepatitis, cirrhosis and acute or chronic liver failure, and HCC. Presentation of acute or chronic liver failure needs to be recognized by everyone, all the clinicians, and you can have a score of FACIT-2, which tells you the chances of mortality. One needs to manage the complications of such patients. They are more prone to develop infections. Nutrition is important. Pentoxifylline and corticosteroids have a doubtful role, except in a few, those who do not have any evidence of infection, or those who have a release score of positivity, where they respond to steroids. And liver transplantation is the ultimate answer for patients with alcoholic liver disease who do not respond to medical therapy. Thank you all for your patient hearing. I'll be happy to answer questions here of your queries.
Thank you, Dr. for a very comprehensive presentation on gastrointestinal and hepatic complications of cirrhosis. The presentation is open for discussion. Any questions?
Most of the liver diseases now are being attributed to endotoxemia through the gut. And these leaks have been found to be more often in females as compared to males. Although this is the reason is not very clear. This is just a recent thought where they have studied the endotoxin levels in the portal vessels and they found the levels to be higher in females.
Secondly, as far as women are concerned, we said at college, and then the, immunological factor was seen. PIP was more common. So I wanted to say in hepatitis also, is it the comorbid infection or is it because it reduces their immunity? If we look at this structure, maybe our treatment modality will it help?
Firstly, I don't have an answer to this. If you look at clinical practice, we still get very few women with alcoholic liver disease. And this gender-specific differentiation in liver disease because of alcohol has not been adequately studied. Women and men, the immunity, we don't expect it to be different in either of them. So I don't see much reason for immunity being an important factor in differentiating the genders. But what has been studied is the presence of alcohol dehydrogenase to be more in females in the stomach, which breaks down alcohol into acetaldehyde and increases levels in them.
Can I ask a third question? The third question is that you did such a wonderful study as far as the from CGI about the alcohol hepatitis, and you said 58%.
That's right.
What I'm interested to know, the people who came, what group of data? Sometimes we say it's poverty, education. Second, because it is a rich Indian data. Was it more the affluent? Was it more the rural? That is one question. Number two, what was the type of the drink that they took? Was it the homemade drink? Was it the Indian drink? Was it the foreign drink? Third, was it just the regular? It was quite often. I think there is, I don't know that there is any politician sitting. If it is not sitting, you see this alcohol abundant, cirrhosis abundant. So I just want to know the richness of this data because I was very happy to see the Indian data.
Yeah, well, you would realize that Punjab is a little different from other states, and that's a rich state. But when we look at the type of alcoholics that come to us, they are rich farmers who have easy accessible to alcohol. The youngsters, the youngest patient that we've seen is about 20 years old. 20 to 30 years group is the one that takes Indian made farm liquor, which has more of, not ILSS, the illicit liquor, which has more amount of alcohol. We analyze the amount of alcohol and it turns out to be 60%. So there's no standardization in that. And they had more amount of trace metals. Arsenic and lead was more common in that patient. So the standard teaching is 10 years and more of a cirrhogenic dose leads to liver disease. In the illicit liquor, even 5 years is good enough.
But this is a very important study and you must give the recommendation to the ministry. So I'm sure as far as the business people are concerned, they have like in the sense that the alcohol contains arsenic. When I was a student, a lot of these materials were used as abortive patients and patients came with paralysis. So our liquors, we said we make good liquors, and I know like Kingfisher of India and here and others are very good. So the metals which are very bad. Number one. Number two, the quantity.
This would hold true for illicit liquor.
Which is very common in India.
That's right.
So which is very common in India, means if we cannot ban, whatever we can, we say, please standardize it. Please look at it. The amount of harm. And to come on the media, because these people now media is influencing the poor, because they see the TV so much,
Right.
Very important, I would say, the data. Excellent.
Thank you, ma'am.
I think we can conclude that
Excuse me. So I have a question. Sir, what is the role of extinct one in our body?
Phase 1 gene is important as far as idiopathic chronic pancreatitis is concerned, but that has been adequately studied in alcoholic pancreatitis. It doesn't hold much significance. In idiopathic, where you don't have any etiology, earlier on tropical pancreatitis used to be more often seen in India. That incidentally is going down, but there still is a group of where you don't have any etiology, either of hypertriglyceridemia or the double duct sign, the annular pancreas, hereditary pancreatitis. One gene is important for the idiopathic group.
There is no any physiological function in our body?
I don't know what physiological function, how it works, that I'm not too sure. Thank you, sir.
So the next question, that's the presentation on that's why Dr. NAMSCON Gupta. Dr. NAMSCON Gupta is retired professor of medicine at GSK Medical College, Kanpur. The request of the president to kindly take to our name and location.
Mr. Chairman and dear colleagues, I'm indeed thankful to Dr. Rajkumar, Director, All India Institute Medical Sciences, Rishikesh, for inviting me and giving me an opportunity to talk in front of this august body of NAMS. Now, alcohol, as has been said again and again and emphasized very clearly by Dr. Bakshi, is a burning problem, and it is all over the world. India certainly will become a hub like CAD, like diabetes in future. And in fact, alcohol and nutrition have a direct relationship. More alcohol, less nutrition goes in body. Just check up alcohol drinking, by the time the person starts taking better food, so more nutrition. Now, what most of the work, my work, has been done by Dr. Bakshi, Dr. Chadda, Dr. Chawla. I don't have much to say, but still I'll try to elaborate certain things. And my talk is mainly for my youngster colleagues who are sitting on the back benches, and they are the future of India and the world. As said by Dr. Bakshi, come on for the research. Yes, come on for the research, but then control also yourself. Because I don't know that how many of you are having binge drinking or regular, not regular, sometime more in parties. So this is mainly for you, because you seniors know almost all about alcohol, which has been elaborated quite widely. So here comes the nutrition and alcohol. I have just reversed the title which I was assigned, because I thought alcohol, of course, आपको पता है, something to know about nutrition. In fact, it is something too much to talk in front of Dr. Chawla, gastroenterologist, who's also. So I just try. Now, alcohol and nutrition, as clarified by Dr. Bakshi also, one serving is one mixed drink of 1.5 fluid ounces and or equal to 5 fluid ounces of wine or 12 fluid ounces of beer or a wine. Now, ounce means, it's an old term, although it's still American term. Ounce means 20 ml. So, this is that. Now, what is this? Alcohol is very high in calories. Mind you, अभी तक हम लोग कह रहे हैं alcohol जो है उसमें कुछ नहीं होता है. Yes, but these calories are trace or anti-calories. It doesn't provide any nutrition. So if you don't have any, like fat has calories, high calories, but it gives you nutrition. Whereas alcohol does not give you any nutrition. And I have just mentioned various calories. You can just imagine. I'm not going to go into detail for, already has been described. Now one thing here I want to emphasize. 5 drinks in 2 hours time, you multiply by 100 calories, it becomes 500 calories, or equal to large McDonald's fries for large apples. सोच लो, McDonald's बहुत खाते हो. Now, how does body metabolize alcohol? As explained earlier, quite a bit. Alcohol contains 7 kilocalories per gram. Absorbed directly from the stomach and intestinal mucosa, metabolized by the liver, and half an ounce per 1.5 hour on empty stomach. Excess is stored as fat in the adipose tissue and liver. Alcohol कैसे fat बन गया? I'll tell you that later. Absorbed alcohol is mainly metabolized in liver, as has been said earlier also, by 2 enzymes. ADH is the most efficient. When alcohol is taken in small amount, ADH is the active one, which metabolizes that alcohol. But if the intake is heavy or it's chronic, then NEOS system gets activated and generated into the liver mitochondria in the liver. And here, by this NEOS system cycle, alcohol is converted to fatty acids and stored as triglycerides. Now here I try to show the thing, and maybe the certain thing which is partly will be answer to Dr. Bakshi's question. Ethanol. Now ethanol, alcohol or ethanol is one and same thing, and Now, ethanol is metabolized in presence of coenzyme, and this HNE converted to acetaldehyde. And then further exposure to other coenzymes, it is converted to acetyl coenzyme. And then this acetyl coenzyme is converted to fatty acids. And fatty acids in 2 parts are converted to triglycerides and ketones. Now here the coenzyme is also stored in the liver. At this stage, the glycolysis happens in presence of acetyl coenzyme, then CH cycle and electron transport system, they are all involved. Now then, here I just elaborate. Number 1, acetaldehyde. It is stored in the liver. Alcohol dehydrogenase converts ethanol to acetaldehyde. And then acetaldehyde dehydrogenase completes the metabolism by forming acetyl CoA, and the buildup of NADH from drinking too much alcohol results in formation of fatty acids. So NADH in fact the byproduct of alcohol metabolism is NADH, and this NADH is nuisance. Ethanol, ADH, acetaldehyde, ALDH2, and then now acetate. It comes to acetate, and NAD plus NADH in the mitochondria. Here they form, and they are inflammatory also to the acetate in their metabolism is inflammatory also to the liver cells and other tissues in the body. In fact, they change the genetic structure of DNA and become carcinogen. Like liver cell carcinoma is very common in chronic alcoholics. Lung carcinoma lung is also there. Acetaldehyde also, when combined with some certain amino acids, they form adduct formations. These adduct formations, they are more in the brain, and so that the encephalopathy occurs. Further, this NEOS system increases rapidly acting oxygen system formation. Then third is increase in NDH and NADH ratio, which is again inflammatory and causes inflammation. Now this is another presentation of alcohol. Let us go first to the toxicity level, the ADH, and ADH is converted to NADH. NADH enters the mitochondrial electron transport chain to generate unstable energy. Then here, second part is excess of NADH leads to metabolic disorders like fatty liver, as said earlier, hyperlipidemia, hypoglycemia. I am particularly not going in detail because there are many reactions in this to produce, not to produce, and not to allow neoglucogenesis, and that's what occurs hypoglycemia in these alcohol patients. Hyperlactatemia, which ultimately leads to hyperuricemia and gouty attacks. Then increased cholesterol, because this reaction also leads to tissue necrosis and fibrosis. So the fibrosis in the liver and other collagen tissues, collagen-containing tissues. Then alcohol comes to microsomal cytochrome P450 in liver. Now P450 is important to metabolize with alcohol when taken in small quantity. If alcohol consumption is more, then NEOS induction occurs, and in fact more formation, the P450 goes in the background and whole thing is taken up by NEOS sponge. And now what does this NEOS does? It comes to acetaldehyde on one aspect, and also here now acetaldehyde metabolism leads to oxygen deficit, leading to hypoxia of the cell and liver damage, tissue damage. Now here I will tell you that there are centrilobar necrosis. Around the portal vein and hepatic vein, the cell death is more because the oxygen concentration is less. Prevents generation of unstable energy from NADH, and this NADH keeps collecting. When NEOS induction causes disturbance in lipid and fatty acid metabolism, increased hydroxylation, proximal beta oxidation, and fatty esterification. And then the next is oxidative stress. Production of reactive oxygen, especially depletion of the antioxidant glutathione, lipid peroxidation, they get activated by liberation of the oxygen
those molecules and oxidants, and the antioxidants are not effective against them, and they cause the liver damage or other tissue damage by altering DNA. Accelerated metabolism of drugs, especially taken narcotics or other drugs, certain other drugs, they also are affected in chronic alcoholism. Now, alcohol also the causes primary or secondary malnutrition. Now, where does it come? What happens? Primary malnutrition and secondary malnutrition. Primary is because alcohol competes with other nutrients. पहले अल्कोहल एब्जॉर्ब हो जाता है, पहले मेटाबोलाइज हो जाता है, so essential nutrient metabolism gets affected, and so less nutrients are available to the body, and so the deficiency occurs. The secondary malnutrition is that once the nutrient deficiency occurs, it causes, especially the folic acid, pantothenic acid, and other vitamins also, they cause, rather they snuff down the intestinal mucosa absorption area, and so the further less absorption, and that is enteropathy, and so the further deficiency. This is again almost the repetition of the same, and this here, that stomach direct injury, irritation, hyperemia, gastric ulcer, then again enteropathy, then teeth are also affected. Teeth, periodontium is affected. Then brain has already been elaborated too much earlier, and then immune system and all these, this is again, and ultimately liver disease is affected. Now, reactive oxygen species, what I was saying, that oxidants, this is that. So, what to do? How to prevent this? Rather systematic. Our bodies process alcohol at a rate of 1 drink per hour. Try not to consume alcohol more quickly than this. So, the swallow, if you have to swallow, then swallow very slowly. Eat before drink. Why? Because if you eat more food is there in stomach, the alcohol absorption is delayed. Consume fat and proteins at least 15 minutes before eating to slow down the alcohol absorption. Another caution, carbonated drinks enhance alcohol absorption, so don't mix up the two. Don't make cocktail of these carbonated drinks and alcohol. Caffeine. Caffeine is good, and only that it suppresses the sedation by alcohol. So the person thinks I don't have any effect of alcohol, but in fact that thing is going on, rather person may become irritable, manic, or lack of sleep and so many things. Men can drink more than women. Why? Men have bigger biomass. Ma'am, this is for you. Men have bigger biomass, have higher body water percentage. So, because alcohol is hydroscopic, and that's why the same amount of alcohol is taken by a woman and the man, then the men will feel less of the side effects as compared to the woman. And then synthesis of enzymes in liver and metabolization of the alcohol is more quickly in men. Alcohol is diuretic. Now, it causes diuresis. Now, then what happens? If person is not taking adequate water in between or after or before, the dehydration occurs. And symptoms of dehydration: thirst, dizziness, lightheadedness, unexplained tiredness, headache, irritability, rapid heartbeat, everybody knows what, and dark or strong smelling urine. Any smelling, the urine which becomes dark, even the overnight urine is dark. Then methods to decrease the risk of dehydration. How? Drink more water before, during and after consumption of alcohol. Alternate alcohol with non-alcoholic drinks. How to control the weight? As said earlier, that alcohol causes increase in weight. To begin with in the beginning. But later on, when the person becomes chronic, addict, then in fact starts losing weight. Again the non-biochemistry, again the oxidants and NADH, they all are tissue toxic. And the protein synthesis is diminished. That's why. If it is diminished in the liver, then hypoproteinemia, hypoalbuminemia, and most of the coagulation important factors, they are not synthesized by the damaged liver, and one gets coagulopathy. In addition to portal hypertension, very thin, but the bleeding tendency is more, so that's why there are the hematemesis and other, there are of course many factors. Then this is 1 month take healthier snacks in between, target low fat for to prevent increase in weight, target low fat, low salt and high protein diet, eat healthy breakfast, resist post-drink greasy foods which are rich in calories. Now, nutrient depletion and malabsorption. Alcohol depletes and causes malabsorption of certain nutrients, I've already said. Some of these result in hangover symptoms also that I'll be telling you what which one are. Alcohol abuse is particularly a risk for deficiency of nutrients. Here I've just tried to put this caption. I'll be the best for you, all these bottles. Now, 12 health risks of chronic heavy drinking. Anemia because of B12 and folic acid deficiency, cancer because of genetic alterations, cardiovascular disease because oxygen molecules and NADH, they are vascular toxic, cirrhosis, already in dementia because of brain suppression and then ultimately damage to the motor neurons, depression because of the alcohol sedation and otherwise, seizures. This is important. Alcoholic can get seizure also. Why? Sometimes the brain gets just haywire and starts getting irritant. Gout, I said, blood pressure is part of the vascular involvement, infectious disease. Now, alcohol decreases the immunity. Because of more NADH, immunity is also decreased. And so, once immunity is low, you know very well that infection chances are more. Now, there is as usual, vitamin deficiency and then pancreatitis, as has been explained earlier by. Then nutrition is I have tried to supplement and just express that what are the deficiencies occur. The vitamin A, susceptibility to infection. आपने लाइफ लाइन में तो सुना था ये इन्फेक्शन कहाँ से आ गया? Yes, it is a cell healthy thing. That's why the infection occurs. Then skin abnormalities occur because of the vitamin deficiency, but the problem is this is a fat soluble vitamin and toxic level can occur very soon. So person should be given vitamin A under strict supervision. Then B1, thiamine, it causes fatigue, neuritis, beriberi. Beriberi of course is not seen, but neuritis is quite common. Then niacin is B3, it causes headache, irritability, insomnia, dermatitis, pellagra. Pentosinic acid, P5, they are all, except vitamin A, they are all B-complex factors. Pentosinic acid is susceptible to infection, poor metabolism of energy, that is it. B6 deficiency of pyridoxine causes deficiency, causes dermatitis, neuritis, anemia, and anemia. Then folic acid, I already told you, anthocyanidin fatty. B12, cobalamin. It is an important coenzyme in hepatic metabolism, and also the loss of or rather decrease in B12 level causes megaloblastic anemia, pernicious anemia, the stomach is because there's too much damage. It's also immune. The fatigue. Vitamin C. Vitamin C is a thing which helps cells to maintain the metabolism. It maintains the wear and tear of the cells. So in case of a deficiency, more infection chances are there. Zinc. Everybody knows that zinc has a healing property. It's a microelement, and deficiency causes poor wound healing, skin inflammation, and loss of taste and smell also part of the thing. Now here I have not added the iron. Iron gets more absorbed, but it is not utilized. So person, chronic thing, can have megaloblastic anemia, can have iron deficiency anemia because of the enterotoxin, but iron is plenty in the body. Then our calcium. Calcium deficiency does occur in alcoholics. And the other thing, so strontium, molybdenum, they are all things, and they in fact decrease the craving for, once they are in plenty, they decrease the craving for further alcohol. In fact, some studies are there, they say that if we use these micro metals, they can prevent the incidence of heavy alcoholism. Poisoning and overdoses. Signs of mental confusion is first coma, vomiting, seizures, slow breathing, irregular breathing. Now, this is something important, irregular breathing. This is because of the acidosis, more of the acetone collection in the body. Hypothermia, because of the dehydration and vasodilatation. And bradycardia. Alcohol is toxic on the heart, and it can cause tachycardia or bradycardia. So the ultimate is, don't wait for all symptoms to present. Overdose and more of the alcohol with severe malnutrition is equal to death. Thank you. Just summarize. Sorry, I just forgot. Sorry. Come. Just to cut short and more for little advice and fun for my student colleagues, a small video which come. Here comes the. This is just a summary what I have said, but in a little interesting way, maybe that the other colleagues they like. Anyhow, this video summarizes all what I have said, only talk is by words and some captions. That's the thing. And the sound is not coming. So
alcohol is a compound of carbon, hydrogen, and oxygen,
which produced as a byproduct when yeast consumes sugars. Once ingested, alcohol has an immediate effect on the body, altering a person's personality and affecting their physical coordination. The more alcohol consumed, the greater the effect. How alcohol enters the body. Everybody reacts differently to the intake of alcohol, but generally, 20% of the alcohol ingested is absorbed into the blood through the stomach, whilst the other 80% is absorbed in the small intestine. However, When the stomach is full, the passageway between the two organs narrows, trapping the alcohol in the stomach, or it's absorbed more slowly. Short-term effects of alcohol. Alcohol affects various centers in the brain, interfering with communication between nerve cells and all other cells. Distorted senses. The cerebral cortex normally controls behavior inhibition, but alcohol makes the person become more talkative, self-confident, and less socially inhibited. It also affects the processing of information from the senses, causing problems with seeing, hearing, and smelling, and impairing the ability to make sensible judgments. Distorted emotions. The limbic system controls emotions and memories, but alcohol distorts this, causing the person to experience exaggerated states of emotion and memory loss. Decreased coordination. The cerebellum is the part of the brain that coordinates the movement of muscles, so increased alcohol levels in the cerebellum can lead to uncoordinated movements and a loss of balance. Nerve and hormonal changes. The hypothalamus controls and influences automatic brain functions. Alcohol also decreases the pituitary gland secretion of antidiuretic hormone, which in turn causes the kidneys to reabsorb less water and produce more urine. Autonomic functions. The medulla controls automatic bodily functions like breathing, heart rate, and temperature regulation. So alcohol's effect on this region can be fatal, as it causes these vital functions to drop or even stop completely. Alcohol affects other body tissues and organs as well as the brain, irritating the lining of the stomach and small intestine, interfering with the nerve endings that control erections, and reducing blood flow to muscles, leading to muscle aches and pain. Long-term effects. The biggest victim of long-term alcohol abuse is the liver, which starts to produce more of the protein that breaks alcohol down. This increases the body's tolerance to alcohol, meaning more drink is needed to get drunk, which in turn leads more addictive behavior. Long-term drinking causes the liver tissues to harden and develop the condition cirrhosis. Alcohol also increases the risk of heart disease, stroke, dementia, myopathy, and decreased bone mass. How is it addictive? Alcohol affects different people in different ways. Some become more happy and talkative, whilst others feel down and depressed. For many, it's followed by discomfort and anxiety, which they feel can only be alleviated by another drink. It is this dependence that can unwittingly trap people in an addictive cycle. Alcoholism. Signs and symptoms. There is no set pattern of behavior that characterizes an alcoholic, but common signs include the effort to drink more than others, hiding how much they've been drinking, and an increased difficulty to function in social settings without alcohol. Withdrawal symptoms are usually experienced within several hours to a few days of reduction in those who drink heavily. These are manifested through increased sweating, hand tremors and shaking, insomnia, nausea, and anxiety. Getting help. Don't be 100. Don't be 100 words about drinking in regards to yourself or others.
So thank you very much.
Good afternoon, ma'am. Ma'am, as you all know, the effect of alcohol is concentration dependent. And it is a known fact that the blood alcohol concentration is in the range of 50 to 150 milligram percentage. There are the inhibition of the inhibitory centers in the brain. So can you please tell me the mechanism involved in the neuronal level of inhibiting these inhibitory centers?
I told you, any nervous system that gets activated and that sends NADH and COA to brain, and that's how it affects. There's a long metabolic thing. I'll not be going in detail, and that is the thing. It suppresses the neuronal function. It stimulates secretion of serotonin in the brain, and that is why this depression comes.
What gives alcohol the preference to select these inhibitory centers only? In the range of 50 to 150.
But pardon?
Is it always that, because it is a known fact that first of all the inhibitory centers are inhibited when the blood alcohol concentration is low. So is there any the receptors of alcohol are sort of preferential, or is there any other mechanism which can explain this? effect?
The receptors are there, metabolites are there, byproducts are there. It's not just one. Alcohol immediately starts acting within 5 to 15 minutes on empty stomach. One is diet, another is metabolites. If consumption is less, then ADH system gets activated in the liver, and from there it goes. And there is some direct flow also from absorption from GIT, and that suppresses the neuronal activity.
But at the sinus level, either it has to be secretion of more of inhibitory substances, or either it has to be the hyperpolarization of the cell.
देखो, मैं physician हूँ, physiologist नहीं हूँ, तो
This question could have been asked to address Yes. Madam has explained to everything. It is very important and I want interaction from the students. 150 ml is too much concentration, let me tell you.
Sorry, sir, 150 milligrams.
Huh?
150 milligrams.
Milligram percent is too much. Even below that, say at 60 or 70%, the neuronal activity suppresses. The broad principle. You have heard about the dementia, you have heard about the depression, you have heard about the neuritis, you have heard about the insomnia. These are the effects of the alcohol because of one or other reason. It has been more than documented because the brain works by the neuronal network. Billions and trillions of neurons are there in our brain, and every neuron has 30-40 connections with every cell. So what happens with the increasing level of alcohol, the entire neuronal activity slows down without causing the clouding of consciousness, which means the further elevated effect of the alcohol. So it's not only the neurochemical substances which are released following the induction by the alcohol, the overall neuronal activity also slows down. That is how it causes it slowing, overall slowing down. You are something more, yes?
But then, we say that the conduction is slowed down in the neuronal circuit. Then inhibitory circuits are also likely to...
Inhibition, yes. Inhibition is mainly by the prefrontal cortex, very important. Inhibition is mainly by by the knowledge of physiology and anatomy, you know that the behavior is regulated by the prefrontal cortex. The inhibition mainly lies in the frontal lobe. So the inhibition starts occurring at euphoric state itself, which is much below concentration, maybe 50 or so. So inhibition is probably first to be knocked out, following the implementation of the alcohol consumption. And it does not occur in total research, you know. Today you may have drink in evening dinner. That is not going to knock out your inhibition until you taste heavy amount of alcohol. Inhibition is knocked down at a very initial stage by 50 or so % of the alcohol in the blood. And that is a very initial phenomenon. Frontal lobe, they get into the lower.
Does this mean that inhibitory centers have got a lower threshold for alcohol?
No. Entire neurons have lower threshold. By the knowledge of physiology, you must be knowing that neurons cannot survive more than 2 minutes of the hypoxia, maximum 10 minutes. And there are vulnerable areas which are responsible for memory, that is hypothalamus, entorhinal cortex, parahippocampal gyrus, and the shade area of the cortex. These are the neurons which are very much vulnerable, and studies have proved, if my remote knowledge goes correct, that alcohol, in chronic alcoholics, the cerebral blood flow also decreases. If alcohol is taken for the longer time, even the cerebral blood flow, how much is the cerebral blood flow? Can you tell me? Oh, you have only done baptism for few of the questions. Okay. It is 60 ml per gram per minute. Average. In infant it may be 90. So even the cerebral blood flow and the electrical activity of the neurons, you know, the neurons produce much of electrical activity.
if the entire telephones are put together, entire telephones of the entire world are put together, one brain generates more electrical impulses than the entire telephones of this globe. So even the neuronal activity also slows down. You want to ask something? Give the chance to other students. I can take someday other physiology class. Yes. Yes.
Thank you, Dr. Rajkumar.
Thank you. I want to congratulate you, but I just want to ask one question because you are not satisfied. Which inhibitory responses is in your mind that you are concerned with?
Yeah.
Because, yes, sir. Because a lot of paper and legal and illegal fights are done on this. So first I want to, because I'm so happy, I want to clap for you, because unless you are, the research cannot be done. So what is the question that you're interested in? Don't feel shy at all of us seniors, please.
Let me say something. You know, Professor Bajaj, our esteemed President of Scientific Committee, has already laid down the reward for the young medicos who will interact more in scientific manner. So you are free to ask, and interactions are very much encouraged. Please ask. Yes. Yeah.
There's a question which ma'am asked me that what sort of inhibition goes away.
Yeah.
As far as I have dealt with the people who have drink and
Oh, you have done also. Very good. Very good. I'm very happy that we have students who are teaching you alcoholics. Very right. Please go ahead.
I've never had any personal experience.
Okay,
Don't tell me that when a person is having alcohol, they do not worry about the consequences of the act. They are free to do anything. They do not fear. The fear is gone. They say it like this. The fear.
Let me explain you. The inhibition goes down, as I said, and euphoria takes over. It is in very lower limit. I don't remember the exact limit of the concentration of the drug.
Can I take a question?
Here we say, yes.
The word alcohol is a depressant drug. There is no doubt. Whether it's low dose, it's high dose, or it's intoxication and above the anti parameter, or it may be indirectly, but somebody can go to get it better. At the lower level, when the levels are 20 or 30 milligrams, at that time, it has anxiety and anxiogenic effect. It lowers the anxiety, and that's how it removes the inhibition. And person appears relaxed and may appear monstrous or may talk more. But as the level increases, it starts becoming judgment, and it starts possessing all the organs, all the areas that the frontal lobe, and at that time the judgment will start occurring, and then it also starts suppressing the respiratory system, all the body systems. So basically the experiment of all the body systems starts. So the initial stages, because when one thinks that alcohol is giving you confidence, it basically is at a lower level, anti-anxiety of that. And because of that, the person appears more confident. And that's the reason that for the dynamic limits have been kept as a 30 milligrams per cent. That's the reason, because the judgment levels increase at that level. So that's the reason you feel overconfident, but you're likely to make error.
Sir, but there is one more part of this inhibition, that inhibition is subjective. What I may see that the inhibition may not be true for a truck driver or a rickshaw puller, because once their inhibition is gone because of their social background or what.
Let me respond. I think you are not convinced what he has said. Inhibition goes slow. It does not mean that the reasoning and judgment also goes slow. It should be very clear. Alcohol has effect on the memory, it has effect on the reasoning, but it does not mean that the reasoning also has gone with the alcohol, certain amount of alcohol. Reasoning and judgment, abstract thinking, these components remain intact up to certain level until the clouding of consciousness occurs. Inhibition goes by the suppression of the neuron, as he has said that it has a sedative effect. Simultaneously, it has euphoric effect also. The person is devoid of inhibition and euphoric also. See the combination. It's a leader combination. Euphoria has static and inhibition has been knocked out. So the person does whatever he feels appropriate at that time for him. But it does not divide the person of reasoning and judgment making. Judgment making and reasoning is still intact. Abstract thinking is still intact. If these things are intact, there is less chance that the person would indulge into some anti-social activity until he is inclined to do that. Most of the time this happens. Until he is inclined to do that, most of the time people pretend to take alcohol and start abusing lessons. Those are the chronic alcoholics which has been documented to be abusing to their wife, to their family. And this is under the effect of alcohol where inhibition though has gone, but because the person thinks that she is my wife, she will not react, they will keep on abusing. But if does not think that they are devoid of reason, then they will not abuse. So there is a difference between inhibition and the other faculty of cognition. Are you satisfied? Keep asking till you are satisfied.
So like inhibitory centers are inhibited and excitatory centers are activated. But in case of people,
this is not a general principle. It depends on the concentration of alcohol in the blood. At certain level, everything is. At certain level, after clouding of consciousness, even the coma may occur in patient may die of alcohol. That is the case that the blood is pretty high. Pretty high, yes.
But people who are constantly consuming alcohol, their receptor state upregulated and they do not feel the same kind of experience at the time when they started. So
I think you are talking about the chronic alcoholic.
Yes, sir.
See, the chronic alcoholics have different problems. The chronic alcoholics are affected by the cortical shrinkage. The cortex also, because of one or other reason, is chronic alcoholic. The cerebral cortex also starts shrinking. The memory, that means hypothalamus, where the memory is encoded and condensed, the hypothalamus are also compromised. Once the cortical shrinkage occurs, then most of the faculties they slow down. So, and the reasons even like in courses of psychosociety, one of the speakers has spoken it. In courses of psychosis, are vernicus and capillopathy, there are particular reasons which are demonstrable by the MRI. These occur because of the compromise of the oxygenation, oxygen consumption, glucose consumption by the neuron. Ultimately, the most of the faculty they get done. Are you clear? I think you are not going to be satisfied. You ask specific questions. Okay, thank you very much. You can come now.
Thank you, Dr. Rajkumar.
Thank you, madam. It was very good. No, madam. There is a different tool altogether.
तो अपने पास भी उतना होना चाहिए था.
Madam is my teacher. He has taught me. I am addressing to students. Sorry for this idiot. I am sitting on your shoulder, so I am not addressing you. Madam is my teacher who has taught me nuclear medicine during my MBBS days. And the very idea of inviting her that first time he is delivering talk, in days to come he would be invited to deliver the talk because I don't like the kind of teaching you are going with, and I am trying to encourage the chalk and board teaching, not those presentations where even sensory memory does not get in and the both and the flight moves on. So she is my teacher and obviously I am able to.
Thank you, Dr. Rajkumar.
Thank you, Dr. Mohammed and Dr. Rajkumar for your expert comments. And with this, we conclude this session.
With this, we come to the end of the previous session. Before we go for the lunch, we have two announcements to make. First is that in the morning we had